Okay, well, you probably remember last year, John, that I told you that if you have 2 orgasms a year, you can reduce your all-cause mortality by 50%. So I don't know whether you've been following that advice. That was the Caerphilly cohort study. Anyhow, here we go. I think that's why John comes back every year, because he learns important facts like that. In terms of the metabolic syndrome, I think we need a more precise patient profile, really, because although these people are overweight, they often have lower urinary tract symptoms, they often have erectile dysfunction. And Roger talked about the dangers of having a lot of testosterone. Well, you're going to hear this afternoon from Jeff Hackett that there's quite a lot of danger in having a low testosterone as well, and somehow we need a balance between the two. Now, there are some very subtle differences between men and women, and perhaps subtle differences between the way they perceive themselves. And we know there are also very subtle differences in the way that men perceive their sexuality in terms of their erogenous zones. But in terms of bladder, we know that the bladder is a very unreliable witness because there are lots of things that can affect the way our bladder works. There are hormonal changes, our age-related disease, arteriosclerosis, anoxia caused by that, local disease and neurological disease. So, yeah, people with the LUTS, they often have problems that we need to identify and seek out. So how does it fit with the metabolic syndrome? Well, perhaps I better tell you what it is, first of all. It's abdominal obesity, hypertriglyceridemia, low HDL cholesterol, often associated with high blood pressure, high fasting glucose, and that leads to increased C-reactive protein. In other words, we have an inflammation in our vascular tree. And importantly, as regards the bladder, increased autonomic sympathetic overactivity. And it's common. It's common in the States, with 24% of the age-adjusted population having the metabolic syndrome, and about 20% of adults in the UK as well. So very common. Now, it's defined, I think, quite helpfully by the International Diabetes Federation. And if you focus on waist circumference, if you have abdominal obesity with the waist circumference in men more than 94 centimeters, and in women 80 centimeters, plus any two or treatment for the following: elevated triglycerides, reduced HDL cholesterol, raised blood pressure, or a raised fasting plasma glucose of more than 5.6. So it doesn't take many of our patients to fit that category quite well, but of course we know that these risk factors cluster together. And this is the old definition of the deadly quartet of diabetes, obesity, hypertension, dyslipidemia. And if you add waist measurement, then you have your diagnosis of the metabolic syndrome. The key thing about visceral obesity is that it's a risk factor, and it doubles the risk of acute myocardial infarction in much the same way as having hypertension or being a smoker. You'll notice here that Peter Amoroso is quite right when he gets people to take more physical exercise, eat more fruit and vegetables, and drink a modest amount of alcohol. Then you're actually reducing the risk of acute myocardial infarction. So we know the metabolic syndrome increases cardiovascular morbidity and mortality, and here you see a population with metabolic syndrome absent. And this is what happens once they develop the metabolic syndrome in terms of the prevalence of coronary heart disease, myocardial infarction, stroke, and increased total mortality and cardiovascular mortality. And importantly, we know that testosterone levels decrease with increasing number of metabolic syndrome components. And you'll see here that if your testosterone is less than 8, okay, then the prevalence of hypogonadism, here this is less than 8 is in yellow. The more number of components you have, the more likely you are to have a testosterone less than 8, less than 10, and less than 12. 50% of the population here having hypogonadism if they've got 4 or 5 components of the metabolic syndrome. And the relative risk of hypogonadism with a testosterone of less than 8 is multiplied by 10 if you have 4 components of the metabolic syndrome. So nobody escapes from the prostate centre without having one of the nurses run a tape measure around their middle. Because we know that if they have a raised waist circumference, then they are 5 times more likely to have diabetes. And we know that waist circumference is a very good measure of visceral fat accumulation. Here you see visceral adiposity measured by a CT scan, and here you see waist circumference bottom. There's a very good correlation. And if you just do a CT scan, you can see this atherogenic, toxic visceral fat in the middle here. And that what happens is, of course, we start young and beautiful, and as we get older and develop the middle age spread, we develop the metabolic syndrome with hypertension, raised triglycerides, low HDL cholesterol, and dysglycemia. And if we don't do something about that, then we're off to see Nick Boone in the cardiovascular clinic, or our chairman, when he's not at the Royal Society of Medicine, in his diabetic clinic. So we need to take a new perspective, really, when we're thinking about the metabolic syndrome. And this lady, she says, I'm not selling sex, I'm selling condoms with a free demonstration. So yeah, a new perspective. So our new perspective might be that metabolic, cardiovascular and endocrine factors contribute to male pelvic health. And there's an increasing evidence pointing between the relationship between lower urinary tract symptoms and the presence of metabolic syndrome from epidemiology, and I'm going to show you some pathophysiological links. So bearing this in mind, when we have to develop treatment strategies for these men, because we need to think about metabolic syndrome, cardiovascular disease, and the links to lower urinary tract symptoms and erectile dysfunction. So once men have developed diabetes, then they're more likely to have erectile dysfunction, LUTS, bladder dysfunction, diminished bladder sensation, poor contractility, increased post-void residual. They're more likely, as I've shown you, to have hypogonadism, and Jeff will cover this in detail this afternoon, urinary incontinence and urinary tract infections. And of course, any of these symptoms can help us to identify what John is encouraging us to do, is to diagnose this disease earlier, before they develop complications. So the genesis of LUTS, secondary to metabolic syndrome, might well be related to hyperinsulinemia, because once you've packed all those triglycerides away in your middle and in your muscles, okay, and we're genetically programmed to be good storers of energy, because in caveman days, if you didn't do that, you didn't survive the winter. And increased sympathetic tone, which increases lower urinary tract symptoms. So we know that larger prostate volume and faster annual BPH growth rates in men with type 2 diabetes, with treated hypertension, with obesity, low HDL cholesterol, high insulin levels, and the metabolic syndrome. And there are inverse associations between the level of exercise and men needing BPH surgery. In addition, if you have a heavy occupational job involving lots of energy, that protects you against getting BPH. And we know that the difference in prostate volume and annual BPH growth between people with a high and low insulin fasting level. So the higher the insulin level you have, the faster your prostate will grow. So once you develop insulin resistance, the pancreas tries to compensate by producing more insulin. High levels of insulin encourage high BPH growth. And of course, once you've got the metabolic syndrome, we know that vessel occlusion is associated with cardiovascular disease, and that's linked to erectile dysfunction, as I'll show you. But of course, these studies establish association are not necessary causality. And in the NHANES study, they discussed that BPH might be an insulin resistance condition, and it might influence 2 pathologies that lead to LUTS, prostate growth and increased tone of prostate smooth muscle. And BPH patients with hyperinsulinemia might have increased sympathetic nervous system activity, which is why alpha blockers are particularly effective at managing LUTS in men. And of course, glycosuria causes polyuria, nocturia, and poor bladder emptying. So there's the LUTS and diabetes story. But at the University of Hertfordshire, we developed this peniscope, which is a new instrument for helping us manage men with a metabolic syndrome. Because losing nighttime erections can be an early sign of vascular disease. I mean, men get about 40 or 50 minutes of nighttime erection, not because they're dreaming about their beautiful partner, but because the penis needs oxygen. And once you lose oxygen to the penis, then you get this tunica albuginea atrophy, which results in subluxation and redundancy, which leads to venous leakage, which stops men getting a good erection. And this is a virtual cavernososcopy. Here's the corpora cavernosa here. And this is where the venous efflux occurs through these channels here. And here you see a beautiful demonstration of the veins coming out of the corpora cavernosa. Now you need those to be healthy to get a good erection, because going from flaccid to erect, as the penis fills with blood, it compresses those veins against the very tough tunica albuginea, and that gives you a firm erection. The problem is that if you are deprived of testosterone because you have diabetes or the metabolic syndrome, then this is a rabbit study which showed that if you take testosterone away, you start to deposit adipocytes within the corpus cavernosum. And once this happens, then of course you can no longer compress the veins that stop the venous efflux during erection. And not only that, oxygen is important to keep the smooth muscle connective tissue healthy in the penis. And here's another rabbit study. Unfortunately, it's rather hard being a rabbit. This one moved to Boston, where they did an angioplasty on the iliac artery. And what cardiologists will tell you, without a stent, you very quickly get rebound stenosis due to smooth muscle hypertrophy. So here we are, 6 months, angioplasty, increasing stenosis. And look what happens to the corpora cavernosa. Red is smooth muscle, blue is connective tissue. As you get increasing ischemia, you get loss of smooth muscle and increased connective tissue in the corpora cavernosa. So, no erections, no nighttime erections, ischemia of the corpora cavernosa. If you don't use it, lose it is the motto. And of course, the converse is true, that we know that men with the most severe coronary artery disease, if we look here, 2 or 3 vessel disease, compared to men with single vessel disease, have more ease in achieving an erection, okay? If you've got less disease in the coronary artery, you get better achievement of erection, you get more firm erections and more frequent erections than the men with 2 or 3 vessel disease. So, yeah, erection hardness is very important. So how can you test for that? Well, I don't recommend you try this at home. I mean, I used to be able to do this, but I had to give it up because my wrists got too weak. In the Olympics this year, they've got a new sport looking at erection hardness, but of course it tells us a lot about that man's cardiovascular status. So perhaps the penis is the window to the hearts of man, or perhaps we could describe it as the barometer of cardiovascular health. And this was a study we did in Hertfordshire. We went to cardiac rehab units. We found 207 men who were attending after a heart attack, and we age matched them with 165 controls in the practices. ED, present in 66% of the men who'd had the heart attack, but half of them had ever told anybody about it. And worryingly, these were middle-aged men, 37% of the controls had erectile dysfunction, and only 43% had ever mentioned it to anybody. But importantly, these men had had ED for 5 years on average before they had their cardiovascular event. So there were missed opportunities to assess cardiovascular risk and manage those risk factors and prevent events using lifestyle changes and using statins and treating blood pressure and identifying dysglycemia. And in fact, 5 years before a cardiac event, but this study by the Montorsi brothers, looking at the time of onset in 300 men with acute chest pain, mean age 62, ED prevalence present in half of them. Again, ED before coronary artery symptoms, 67%. And the mean interval before you get cardiac symptoms after developing ED seems to be about 38 months. So 3 years for symptoms, 5 years for a heart attack. So it may be that therapies designed to alter cholesterol metabolism and improve endothelial function may be beneficial because it may help lower urinary tract symptoms, and it may help erectile dysfunction. And the evidence, I think, is yet to be conclusive, but here we have an example from a meta-analysis comparing lifestyle with pharmacotherapy for CV risk factors. And you'll see here that lifestyle is as effective as lowering cholesterol with statins at improving erectile function score. This is the mean increase in erectile function by either lifestyle changes or taking a statin. And just to show you how helpful lifestyle modification can be, this was a single-blind trial, 110 obese men, middle age, all had ED, but they didn't have diabetes, hypertension, or hyperlipidemia, and they're randomized to pretty intensive lifestyle advice and encouraged to lose weight, and they compared that to men just given good advice, but not really encouraged to follow it. And it's a 2-year follow-up, and you'll see here, if you look at the intervention change over 2 years compared to the less active encouragement, BMI goes down, erectile function score goes up, about the same as using a statin, systolic blood pressure falls, total cholesterol falls, and we could put John out of work really because HDL cholesterol goes up. Just as good as a drug really. So I think the take-home message really is what fits your busy schedule better, exercising for an hour a day or being dead 24 hours a day? And take-home message, if you do 30 minutes exercise twice a day, you increase your insulin sensitivity for about 30 hours. I tell all my diabetic patients that. If you go out for a 20 to 30 minute exercise session, it improves your insulin sensitivity for 15 hours. That's a bit of a bargain, isn't it? So how many people here exercise twice a day? Hands up. Oh, a smattering. How many people are now going to exercise twice a day? So there, Mr. Chairman, I rest my case and leave time for the panel discussion.